Hello everyone, a very good morning to all of you. So today let's talk about infective endocarditis. So it is one of the most commonly revolved topic among the previous year questions. So let's break this down and you are not going to get any doubts or confusion in infective endocarditis. Okay. So before moving, we all know that the heart has three layers or three chambers, whatever you describe. So it is called as endocardium, myocardium, and epicardium. Okay. So we all know the endocardium is the one that lines the chambers of the heart. Okay, the heart has four chambers: right atrium, left atrium, right ventricle, left ventricle. So this lines the chambers of the heart. What is its function? It forms a thrombogenic surface. What do you mean by that? It prevents the platelet clot formation so that the blood flow is smooth. Okay. And myocardium, we all know it is nothing but a muscular layer. So it is mainly responsible for the contraction of the heart. So the left ventricle, it has more muscular activity than the left atrium because it has to pump the blood throughout the body, as I talked in the previous sessions. So muscular activity is more in the left ventricle. Myocardium is responsible for that, and it is responsible for contraction of the heart. Okay, epicardium is the one that lines the outer surface of the heart. It has coronary vessels. Okay, apart from this, we also have what is called as the pericardium. So pericardium is basically a sac. Okay, pericardium is a sac that lines the heart. Okay, it is a sac that protects the heart. So these are all the very basics. So it has endocardium, myocardium, epicardium. So the endocardium is the one that lines the chambers of the heart. The myocardium is a muscular layer. Epicardium is the outermost structure of the heart that has coronary vessels. And pericardium is a fluid sac that protects the heart from the rib cage. Okay, now moving on, as the name implies, infective endocarditis. Now you will come to understanding that the endocardium is getting affected, the endocardium is getting damaged. So there is some abnormality in the thrombogenic surface. So there's going to be some abnormality in the blood flow. This is the very basic of infective endocarditis. So what happens in certain diseases? Okay, in certain diseases, say for example, congenital heart disease or rheumatic heart disease or prosthetic valve replacement or cardiac transplant patients, these patients will have impaired, okay, impaired or turbulent blood flow, which means, say for example, if I'm rubbing my skin like this, it's not going to cause any kind of an abrasion or a trauma. So imagine if I keep on rubbing the skin very hard and forcefully, roughly, at some point of time heat is generated and the epithelium is going to get damaged. Similarly, these patients will have rough or turbulent blood flow. So when there is rough or turbulent blood flow, okay, the endothelium, which is lining the blood vessel of the endocardium. So endocardium is responsible for smooth blood flow. We know that the blood vessel is lined by endothelium. So the endothelium, because of this rough or turbulent blood flow, is getting damaged. So endothelium is getting damaged. So we all know any damage to the body signals in the form of inflammation. So what happens? Damage to the endothelium because of the turbulent blood flow, because of these situations, is going to trigger platelet formation. Platelet plug is formed. So platelet or clot formation takes place. So platelet or clot formation takes place, and what happens is, because the endothelial layer is getting damaged, the layer below the endothelium has collagen in it. So the collagen forms and exposes the collagen that results in the platelet clot formation. So the platelet formation results in the trigger of or release of fibroblast. What happens? A fibroblast release collagen. So the combination of platelet plus a fibrin network plus a few inflammatory cells is vegetations. Okay, so endothelial injury results in clot formation, triggers the fibrin and the collagen, so that results in a formation of vegetation. So vegetation is basically made up of platelets, fibrin network plus inflammatory cells. So at this point it is a sterile vegetation. So now, am I right in saying that this formation of vegetation or the inflammation of the endocardium, that is endocarditis, does not or it is not still involved or invaded by the bacteria? So I'm going to call this as non-bacterial thrombotic endocarditis. Okay, it is non-bacterial. So till now there is no bacterial involvement. It is just because of the turbulent blood flow there is inflammation of the endocardium. That is nothing but it is the damage to the endothelium results in inflammation. We call it as endocarditis. Itis means inflammation. So turbulent blood flow results in damage to the endothelium. Any damage the body signals in the form of clot formation that results in the formation of vegetation. Okay, so now this is not involved by or invaded by any bacteria, so it is non-bacterial thrombotic. Thrombotic means clot that is formed because of injury. Thrombotic endocarditis. Okay, so this is non-bacterial thrombotic endocarditis. Now what happens is, in case of any dental procedures, okay, in case of any dental procedures or skin infections or IV drug users, urinary infections, all these is going to result in entry of the bacteria into the bloodstream. We call it as bacteremia, isn't it? We call it as bacteremia. Okay, so till now there's non-bacterial thrombotic endocarditis. So once some procedures, some dental procedures or skin infections, IV drug users, urinary infections release the bacteria into the bloodstream, that results in bacteremia. This is where the main process kicks in. Okay, so this results in a formation of what is called as the infective endocarditis. Okay, this results in the formation of infective endocarditis. So what happens, say for example, staphylococci or viridans group of streptococci or enterococci or staphylococcus epidermidis. Okay, see these organisms, they have a capacity, they release addisons. Okay, these bacteria release addisons that bind to the vegetation. The vegetation is already formed, it was sterile, later it was invaded or it is invaded by the bacteria. So these vegetations become non-sterile. So what happens, these bacteria, they penetrate into the fibrin network. Okay, they penetrate into the fibrin network, and what happens, they multiply inside very deep, they multiply deep into the vegetations. So inside the vegetation they multiply rapidly. So what happens when I give antibiotics, it cannot penetrate the fibrin network, or it finds very difficult to penetrate the fibrin network. So the antibiotics becomes inactive. Okay, so now you have to tell me that the organisms are not resistant to these antibiotics, they are hidden from the antibiotics. Okay, these organisms, since they are present very deep into the vegetations, they are protected by the fibrin network, so they are hidden from the antibiotics, they are not resistant. Okay, so one key feature about staphylococcus is they invade newly formed, newly infected valves. That is, they invade the sterile vegetations. Okay, streptococci is they invade the already infected valves or already infected patients who are having any previous history of endocarditis or prosthetic valve replacement, whatever it may be. So these patients, sorry, these organisms invade the infected valves. Staphylococci invade the newly, sterile vegetations also. Okay. Now, moving on, Staphylococci, if you see, the onset is going to be rapid. When a Staphylococci infection bacteria goes and infects the sterile vegetations, it is going to be acute, rapid, within days. And the prosthetic valve is going to get damaged more rapidly. Okay, valves is going to get damaged rapidly, and there is going to be increased risk of embolism. There is increased risk of embolism. So I'm going to call this as acute infective endocarditis. So in cases of acute infective endocarditis, Staphylococcus is going to be predominantly involved. These patients will have, the disease progresses within the day, and the patient is going to get symptoms within the day. Valves are going to get damaged rapidly, and there is increased risk of embolism. Whereas on the other hand, if you look at streptococci, exactly opposite to this, days to weeks, and the valves are going to get damaged slowly, and there is less risk of embolism. Okay, I'm going to call this as subacute infective endocarditis. This is acute infective endocarditis, and this is subacute infective endocarditis. So the organisms involved in subacute infective endocarditis is streptococci, Viridans group of streptococci, and the organisms involved in acute infective endocarditis is staphylococci. So you will be very clear in it. Now, moving on, see, I'll tell you what are the complications that might occur because of this infective endocarditis. The right atrium, it drops the blood into the right ventricle via the tricuspid valve. So, okay, and now from the right ventricle, it goes into the pulmonary artery via what is called as the pulmonary valve. And on the other hand, if you see, left atrium drops the blood into the left ventricle via the bicuspid valve or mitral valve. And left ventricle is going to take the blood to the aorta via what is called as the aortic valve. Very basics, right? So the right atrium is going to receive blood from inferior and superior vena cava. The left atrium is going to receive the blood from pulmonary veins. Okay, so now what happens is these infective endocarditis patients, the most commonly affected valves will be the tricuspid and the bicuspid or the mitral valves. So these two valves, they are going to get affected most commonly. Okay, so now what happens, these patients, as I told you, they form vegetations, that is they form a blood clot, right? So these blood clot will be very, very fragile. So what happens, it might break down. That is what we call it as embolus. Embolus. So if it moves, it can be a septic emboli, it can block the brain, kidney, spleen. Okay, it can be a pulmonary emboli if the infective endocarditis occurs in the tricuspid valve, that results in pulmonary emboli. Okay, it affects the lungs. So these is one of the complication of infective endocarditis. There's a formation of embolus because the valves are getting affected. Tricuspid valve supplies the pulmonary artery. Any emboli, the lungs is going to get affected. Again, the aortic valve, it supplies the entire body, so it can go to brain, kidney, spleen, whatever it may be. And now the next complication will be abscess. The next complication will be abscess. So the major complications of infective endocarditis will be embolus, abscess. Okay, so these patients, if you see, they will have what is called as, these patients will be dizzy, fatigue, and over a period of time, the valves are going to get infected. Now you have to tell me what happens if there is a constant damage to the mitral valve or a bicuspid valve or a tricuspid valve. Is the blood flow is going to come from the atrium to the ventricles, but because the valves don't shut, there is going to be regurgitation of the blood again back to the left atrium and the right atrium. It is obvious, right? See, when the pressure is more, the blood flow from the higher pressure to the lower pressure. Whenever the pressure in the right atrium or the left atrium is more, it is going to go to the left or the right ventricles. Imagine if the pressure is more in the right and left atrium, the blood is pumped, but again the pressure in the left ventricle and the right ventricle does not increase because the valves are not shutting off. Only when the valves shut off, the pressure is going to build up and it is going to increase, it is going to pump the blood. If it is not increasing, the blood again is going to go back to the right atrium and the left atrium. That is called as regurgitation of the blood. So once there is a constant regurgitation of the blood, that is going to result in what is called as the cardiac failure. So what are the three major complications of infective endocarditis? Embolus, abscess, and cardiac failure. So why we learned? Because of the valves are predominantly affected in infective endocarditis, that is the tricuspid and the bicuspid or the mitral valves are commonly affected. So defect in the valves, it is going to result in embolus and regurgitation of blood, cardiac failure, and also results in abscess formation. Okay. So now moving on to patients who needs antibiotic prophylaxis for infective endocarditis. So as I told you, infective endocarditis is because of turbulent blood flow. Okay, congenital heart disease patients, rheumatic heart disease patients, prosthetic valve replacement or cardiac transplant patients, these patients require infective endocarditis. The dental procedures that require infective endocarditis prophylaxis is any kind of scaling and root planing, periodontal surgeries, extractions, periapical surgeries that goes beyond the apex, on intraligamentary injections. Intraligamentary injections. And of course, dental implants. So these procedures definitely require antibiotic prophylaxis. Okay. So what antibiotic prophylaxis should I give? I can prescribe amoxicillin 2 grams orally 30 to 60 minutes before the procedure. Okay, amoxicillin 2 grams orally 30 to 60 minutes before the procedure. If the patient is allergic to amoxicillin, I can give cephalexin. Okay, cephalexin 2 grams orally 30 to 60 minutes before the procedure. Now, if the patient is not able to take oral, then I can prescribe ampicillin. Okay, then I can prescribe ampicillin 2 grams IV or IM. If the patient is allergic to penicillins, then I can give cefazolin IV or IM. So this is the antibiotic prophylaxis for a patient with infective endocarditis. So this is about infective endocarditis. So we learned what is infective endocarditis, what is non-bacterial thrombotic endocarditis, what is infective endocarditis, what are the causes of infective endocarditis and how you treat those patients, and what is the antibiotic prophylaxis, and what are the complications of infective endocarditis. So infective endocarditis is one of the very important topic. It is the most commonly asked topic in previous year MCQs. So I want everyone to read the very basics of infective endocarditis, the organisms, why it is called as acute, why it is called as subacute, what Staphylococcus invades what type of valves, and Streptococcus invades what types of valves. So if you know the basics, you can connect everything. Okay, so with this basic concept, you can dig deep into the infective endocarditis, and whatever you learn will be very easy for you. So thank you so much. In the evening session, we'll talk about a few MCQs in the infective endocarditis, and I'll be talking about a few concepts which I don't discuss here. I'll be discussing there in the MCQ session. So thank you so much. Have a nice day.